Hello everyone. Thank you very much, Ryan. It's a pleasure to be here today and give this talk. I was asked to talk on the diagnosis and treatment of H. pylori infection. However, I'm going to present some background information for a couple of reasons. First, I think background information on the infection allows us to make appropriate decisions regarding the diagnosis and treatment of the infection. And secondly, it's really important to recognize that background information is pertinent to H. pylori because this is the major cause of gastric ulcer, duodenal ulcer, and gastric cancer worldwide. And the third reason to try and understand the infection in its total, all of its manifestations, is because you undoubtedly will receive questions on H. pylori infection on the internal medicine boards. So with that in mind, what I'd like to do today is present the epidemiology and the pathogenesis of the infection. Then I'll review the immunology of H. pylori infection, focusing on the cellular response and some of the work, published work from my laboratory. Then we'll review the several diagnostic tests available to us for diagnosing H. pylori infection, and then how we go about mapping, what's called gastric mapping, and then finally, and very important, different regimens for treating H. pylori infection will be reviewed at the conclusion. So a number of years ago, a group of German investigators began receiving H. pylori from clinicians around the world. The clinicians had obtained biopsies, cultured H. pylori, and they sent the H. pylori to a group of investigators in Germany. And these investigators sequenced 7 housekeeping genes plus the virulence gene VAC-A, and using these sequences, they were able to create a phylogenetic tree or an evolutionary tree that is really based upon differences and similarities in the genetic or the sequences, base sequences of these 8 genes. And this allowed them to extrapolate from the genes a phylogenetic tree. And using this phylogenetic tree, they were able to show in a series of beautiful work published in Science, Nature, and eventually in PLOS Pathogens. And what they showed was that H. pylori originated in Northeast Africa. If you notice, I don't really know how to point to this. Maybe here we go. Originated in Northeast Africa about 58 to 60,000 years ago, and migrated out of Northeast Africa with human migrations across Africa into Southern Africa, and then into the Fertile Crescent, which is now modern-day Iraq. From there, H. pylori was carried by migrations back from Western Asia, back into Europe, across Asia into the eastern part of Asia, and then down through the islands into New Zealand, and this is, and then from there also it moved across the Bering Straits into North America and down into South America. Importantly, H. pylori was also carried from West Africa through the slave trade to South America and to the United States. And the H. pylori that was carried into Europe was eventually carried through colonial expansion to the United States, to South America, and to South Africa and Australia. Over time, 5 different genotypes developed: HP Northeast Africa, HP Africa 1, that's the southern and the West Coast Africa strain of a species of H. pylori, HP Asia, and HP Europe, and then the HP East Asia really developed two subgenotypes, HP Amerindian and HP Maori. These studies allowed the investigators to draw a number of very important and interesting conclusions. First, H. pylori probably first made its zoonotic jump to humans about 100,000 years ago in Northeast Africa. H. pylori migrated with humans out of Northeast Africa about 60,000 years ago. And colonization of the stomach by humans in these diverse geographic locations resulted in the 5 genotypes and the 2 subgenotypes that I just mentioned. Patterns of genetic diversity in H. pylori mirror human genetic diversity. For example, the genetic diversity decreased in both humans and in H. pylori the farther the human group migrated out of East Africa. And finally, H. pylori co-evolved with humans with H. pylori infection migrating out of Africa with the humans, allowing for the coevolution to occur. So a follow-up study published about 10 years ago in Science was the result of a group of Italian mountain climbers who discovered in a glacier on the border with Austria a frozen Copper Age human being that was eventually shown to be 5,300 years old. And in a follow-up study published by a group of Austrian investigators, they basically sequenced H. pylori from different regions of the gastrointestinal tract. And this radiograph here shows that they sequenced material from the stomach, from the small intestine, from the upper colon, and from the lower large intestine. And what they showed was several things. First of all, that most of the H. pylori was present in the stomach, particularly in the proximal stomach or the corpus. There was a significant amount also in the antrum, smaller amounts in the small intestine, and very little in the large intestine. They sequenced the H. pylori, and they showed that it was 93.5% H. pylori Asia and 6.5% H. pylori Northeast Africa, confirming that the H. pylori that is present in Europeans as far back as 5,000 years ago originated not only from Africa, but through the Fertile Crescent in Western Asia. And then migrations carried it into Europe. So let's move on then. Worldwide, H. pylori in a number of studies studies conclusively showing that H. pylori infects approximately half of the world's citizens. It's important to recognize that gastritis occurs in virtually 100% of people that are infected, both children and adults. Ulceration occurs in approximately 10%. This depends on the study population and the environmental conditions of the study population, but in general, up to 10% of chronic carriers can go on to develop either gastric and or duodenal ulceration. Adenocarcinoma occurs in approximately 3%. Some of the best studies come from Hong Kong, published in the New England Journal of Medicine and in Gastroenterology. And about 1 to 2% of people that are infected will develop malt lymphoma. In the developed world, namely North America and Europe, less than 10% of children are infected, and approximately 10 to 15% of Caucasians are infected. When we first started studying H. pylori infection, it was thought and shown in a number of studies that about half of Caucasians were infected, but there's been a general decline in the prevalence of H. pylori in Caucasian adults in the developed world. However, it's important to recognize that there is still a higher incidence or prevalence of H. pylori in the United States, in African Americans, and in Hispanic Americans. And in a recent study from Houston, 53% of African Americans and 48% of Hispanic adults were carriers of H. pylori infection. Now, in contrast to the, in general, very low prevalence of H. pylori in children and adults in the developed world, in the developing world, 60 to 90% of children are infected and 80 to 90% of adults are infected with H. pylori. So what are the key features of this epidemiology? First, in the developing world, 1 to 3 months of age, during the first 1 to 3 months of age in the developing world, infants acquire the infection, whereas it's usually up to about 32 months of age, infants will acquire the infection when they're exposed in Europe and North America. Transmission is generally through, well, almost exclusively from person to person, particularly mother to child, and possibly through contaminated water. Familial clustering is an important feature of the epidemiology, and this is due to intrafamilial transmission due to close proximity. Now, as I just mentioned, the prevalence of H. pylori infection in North America and in Europe is decreasing, and it's lowest in non-Hispanic white adults. The risk factors for H. pylori infection include poor hygiene and reduced socioeconomic resources, often promoting close intrafamilial clustering. And finally, it's very important in terms of therapy, which we'll discuss a little bit later, to recognize that whereas in the developing world, about 12% of people who clear their infection will reacquire the infection. This, of course, depends on the location, the socioeconomic status, and the prevalence in that location. Whereas in Europe and in the United States, less than 1% of people following clearance will acquire the infection. Now let's look at the key manifestations of H. pylori infection. See, Ryan, maybe you can tell me how I can remove some of the lower panels here so that I can have more room on the screen to see what I have here.
Let's see. What panel? So we can see your full slide that's coming through on our end.
Okay. I'm glad you can. I can't.
I wonder if you can minimize. Is there a way to minimize the panel that? What's on the panel?
Yeah. So I minimize them. So that's much better. Thank you.
Perfect.
Okay. So under normal circumstances, people with a high gastric acidity will acquire the infection, and so the bacteria will infect normal gastric mucosa. In acute H. pylori infection, there often is a decrease in the acidity as a consequence of the acute inflammatory response, but over time, individuals will develop chronic H. pylori infection. I want to emphasize that if a person is not treated with antibiotics, they will continue to have chronic H. pylori infection. So once infected, you will almost always be infected for life. The infection can infect either the antrum and an antral predominant gastritis. This is generally asymptomatic, although a small proportion, as I mentioned earlier, about 10% can go on and develop duodenal ulcer. Probably even more common is atrophic pangastritis, and this also is generally asymptomatic. But some people with non-atrophic pangastritis can go on to develop Malt lymphoma. What concerns us the most is corpus predominant gastric cancer, gastritis, which generally can progress to atrophic gastritis. And it's in this condition that we see a predominance of gastric ulcer disease. although many of these people will be asymptomatic, it's important to recognize that the atrophic gastritis can progress to metaplasia, dysplasia, and of course, gastric cancer. So we're most worried about gastric cancer in people with dysplasia who have corpus predominant atrophic gastritis. The individuals with antral predominant gastritis, by and large, although this is not 100%, by and large, these individuals will not develop gastric cancer, but we are seeing more and more people with antral gastritis. Usually these are people whose corpus gastritis has moved into the antrum, so they have really a pangastritis that can go on to develop gastric cancer. Let's see here. So, what about gastric cancer? Well, it is important to recognize it's the fourth most common cancer worldwide and the second leading cause of cancer-related deaths, over 800,000 per year in 2015, and undoubtedly much higher 5 years later. So it's a devastating disease with a 5-year survival, again, depending on the population, of around less than 15%. A number of studies have reported with some very good epidemiology that up to 90% of people with gastric cancer worldwide, their gastric cancer is due to H. pylori. So what about gastric cancer? Well, proximal gastric cancer is an important problem. The risk factors, as we all know, include gastroesophageal reflux disease, Barrett's esophagus, which is associated with reflux disease, obesity, male gender, white race, and smoking. The incidence of proximal gastric cancer is increasing, particularly in North America and Europe. In contrast to distal gastric cancer, which is the most common form of gastric cancer, their risk factors are H. pylori infection, low socioeconomic status, smoking, salty smoked foods, reduced fat, reduced fruits and vegetables, and importantly, male gender and late age. The incidence of gastric cancer is, in some areas of the world, is increasing, although due to increasing population, the overall incidence of distal gastric cancer appears to be increasing. It is distributed throughout much of the developing world, including China, Asia, Russia, Eastern Europe, and Central and South America. Other important features of gastric cancer include the following, and it's of course important to recognize that features of cancer depend on the local prevalence of H. pylori, the recurrence rate, and the dominant histology in the study population. Nevertheless, gastric cancer, just to summarize, is strongly associated with gastric ulcer, corpus dominant gastritis, severe atrophy, and intestinal metaplasia. It's far less common to be associated with gastric polyps and non-ulcer dyspepsia. Also, it's very uncommonly associated with duodenal ulcer. Interestingly, 5% of H. pylori infected Japanese develop gastric cancer at 10 years. I mean, it's a huge problem in Japan, even though it's obviously a developed country. Why is that? There's probably a lot of, people think it probably has a lot to do with cofactors, such as the consumption of nitrates in certain Japanese foods. And finally, it's regarding gastric cancer. H. pylori eradication during early infection significantly reduces the risk for gastric cancer in a number of very well done studies. Okay, let's move on to H. pylori associated inflammation. You can see this biopsy here showing multiple organisms lining the gastric epithelium. Often they dominate the base of the crypt where the stem cell niche is located. And it's thought that H. pylori in the gastric niche actually impacts stem cells, which then migrate up and replace senescent epithelial cells along the gland, carrying whatever changes, tumorigenic changes H. pylori has induced in the stem cell. As I mentioned earlier, virtually 100% of people will develop chronic inflammation if they are not treated. Chronic inflammation in a sizable proportion will progress to atrophic gastritis, and then intestinal metaplasia, dysplasia, and finally gastric adenocarcinoma. And this sequence was really beautifully defined by Paola Correa, who Ryan and I just got through discussing, was previously at LSU for a number of years. Following Katrina, he relocated to Vanderbilt. And in addition to this, defining this cascade, Dr. Correa has the distinction of being in his early 80s and still having an NIH R01 grant application. There are a number of bacterial determinants that impact the progression through this cascade. And these include a number of factors, including urease, which allows the H. pylori bacteria to survive in a highly acidic environment. It neutralizes the acid of the stomach. There are adhesions, key adhesions that allow the bacteria to adhere and inject through its type 4 secretory system the CAG-A protein into the epithelium. The CAG-A pathogenicity island is a sequence of genes in the H. pylori genome, and one of the genes encoded by the pathogenicity island is the type 4 secretory mechanism that allows H. pylori through a stylus type structure to inject into the epithelium the CAG-A oncoprotein, which dysregulates a number of phosphorylated signaling pathways and thereby disrupting the ability of epithelial cells to undergo normal physiology. Another important, the CAG-A pathogenicity island is important. It has found its way onto both the GI boards and the internal medicine boards because the CAG-A pathogenicity island is the main virulence factor associated with the development of gastric cancer. Not all H. pylori carries CAG-A, but those bacteria that do carry it predominate in certain regions of the world, and those are the bacteria that are associated with H. pylori-induced, ultimately, gastric adenocarcinoma. Virtually all H. pylori carry the vacuolating cytotoxin, another virulence factor. Another important factor is phylogenetic origin of the bacterium. And how does that play a role? And I think there was a beautiful study that I'd like to review with you from our colleagues at Vanderbilt. They study H. pylori infection and gastric cancer in Colombia, where Dr. Correa is from. And they began studying the prevalence of H. pylori in two cities, a city on the coast, Temuco, and a city 125 miles away in the mountains, shown in these two areas. And although these two cities were only 125 miles apart, the prevalence of gastric cancer on the coast was shown to be 6 per 100,000, whereas in the mountains, 150 per 100,000, despite similar prevalence of CAG-A and BAC-A in isolated bacteria from both regions. They went on to show that in the low, the prevalence of or the low risk coastal residents of Colombia in Temuco were colonized predominantly by HP Africa 1, and that's in red here in this phylogenetic tree. And the high, corresponding to the open circles here, the dark circles here correspond to the high risk region H. pylori isolates, and they were predominantly from the mountainous region 125 miles away. And interestingly, what they went on to show, so how would one actually explain this? So they went on to show that the H. pylori from the coast were predominantly HP Africa, whereas with some HP Europe, but the bacteria, they're isolated from residents of the high mountainous region, again, only 125 miles away, were predominantly HP Europe. And they went on to show that the HP Europe, in contrast to HP Africa, have a much higher incidence of inducing DNA damage, reflected here. And you can see down here the more severe and early dysplastic lesions in some of the individuals' biopsies from the mountainous region who were infected with HP Europe. So HP Europe strains are known to induce significantly more DNA damage and more premalignant lesions than HP Africa. And it's very likely that the difference between these two regions is due to the original colonization of these two regions, named the coast was colonized by slave traders, and the African population in Tomoko on the coast is significantly higher than in the mountains, and the mountainous region was colonized by the Spanish conquistadors 500 years ago. So they brought HP Europe, whereas the African slaves in that area on the coast were brought with them HP Africa. So what about other determinants? Namely, there are a number of host determinants, including genetic polymorphisms in some of the immunoglobulins, in some of the cytokines, including IgA and TNF. Iron deficiency and a high salt diet promote progression through the cascade, and a number of other factors, including age, T effector and regulatory cell responses, the gastric microbiota, and the epithelial cell tumor expression. So my laboratory has actually studied these latter four, and I'd like to just quickly review them. We know that H. pylori has infected children for millennia, and these are two mummified children on the left from Peru and the right from Chile. And their gastric contents were examined for H. pylori, and they were shown, despite their obvious age, to contain H. pylori. And the H. pylori was European, was actually from Europe, delivered from the European invasions. And importantly, well, I just want to make one other point with these mummies. If you'll notice the face on this mummy and a little bit here, in contrast to the mummification that occurred in Egypt, the indigenous people of the Andes actually removed the skin and replaced it with mud, as shown clearly in this child mummy here. So children have significantly less inflammation, although they always get some degree of inflammatory response compared to adults. They have a markedly reduced level of ulceration, and gastric adenocarcinoma and multiple lymphoma is so unbelievably rare that it, in effect, does not exist in children compared to adults. What about the inflammatory response? Well, as I mentioned, H. pylori, when it comes in contact with the epithelium, although it does not invade the epithelium or the lamina propria, it injects into the epithelial cells through its type 4 secretory mechanism, CAG-A, which has an important ability of disrupting phosphorylation-dependent signaling pathways. CAG-A, it can then be detected by dendritic cells, which then induce naive T cells towards in general, a Th1 and a Th2 inflammatory response, leading to the production of pro-inflammatory Th1 cytokines. Also, the pathway induced by H. pylori can progress towards a T regulatory cell. T regulatory cells have an important ability to downregulate the inflammatory response. And the results of a number of studies comparing H. pylori infected adults with infected children have shown us that despite similar H. pylori genotype, bacterial burden, and virulence factor expression, there is a reduced Th1 inflammatory response in the children, increased H. pylori induced T regulatory cell number and T regulatory cell response, implicating the downregulation in the inflammatory response in children, and likely the lower incidence of duodenal ulcer, gastric ulcer, and the absence of gastric cancer is due to the much higher level of T regulatory cell responses. Also, we have studied the bacteria in H. pylori and shown that in children have a more diverse bacteria, less firmicutes, and more proteobacteria. We're now looking further to see if we can identify any particular bacteria that might help us understand the lack of progression through the inflammatory cascade in children compared to adults. Just want to mention that T regulatory cells downregulate the inflammatory response through inhibitory cytokines such as TGF-beta and IL-10. They also induce cell killing through inducing apoptosis in T effector cells. They disrupt metabolism. They inhibit dendritic cell maturation and function, all of which tend to downregulate the inflammatory response. So that in summary, the consequences of reduced H. pylori inflammation in children is a reduced incidence of gastric ulcer, duodenal ulcer, gastric cancer, and lymphoma. And so comparing pediatric H. pylori immunobiology with that of adults allows identification of the factors that promote H. pylori disease. Two of the things that we're actually doing is we're studying patients in both Chile and the United States at each of the 6 stages leading to and including gastric cancer. So we're characterizing their 16S ribosomal DNA to identify the bacteria, and we're using gastric biopsies to generate stem cell organoids to identify epithelial cell cancer gene expression using RNA-seq. So these studies are ongoing, and the purpose of these studies is to determine whether microbiota and/or transcriptome profiling can provide important clues as to the pathogenesis of gastric cancer in adults, but not children, and to help us understand or identify perhaps a biomarker that would reflect the likelihood of progression to gastric cancer. So let's move on now to diagnosis, mapping, and therapy. So what are the clinical indications for testing for H. pylori? Well, certainly subjects with gastric symptoms, especially if they're from a developing country or from Eastern Europe, Russia, China, Central America, or South America. We see a lot of people from Eastern Europe. There's a small population of Russians living in Birmingham, and obviously a number of Chinese people from China here at UAB in the graduate programs, and their children often are seen in our clinic, and not infrequently do we find H. pylori infection. Well, actually more frequently than in people born in the United States. Certainly subjects with gastric and duodenal ulcer disease and uninvestigated dyspepsia probably warrant evaluation for H. pylori infection. Subjects with unexplained iron deficiency anemia and idiopathic thrombocytopenic purpura have a higher incidence of H. pylori infection. The presence of gastric metaplasia should cause one to most definitely determine whether or not the person is infected with H. pylori. And then subjects for whom long-term NSAID therapy is anticipated, in part because there's at least one study showing that H. pylori infection may exacerbate NSAID complications. The NSAID ulcer disease is exacerbated in the setting of H. pylori infection. And finally, family members of a patient with gastric cancer or multiple lymphoma. It's been suggested in a number of studies that one should discontinue PPI therapy and/or antibiotics about 14 days before testing if the test involves endoscopic biopsy. So what are the available tests? Well, probably the best test is the urea breath test. So H. pylori urease cleaves ingested C13 or C14 labeled urea into ammonium and labeled carbon dioxide, which is then measured in the breath. This is clearly the most sensitive test. Almost 100% of people who are infected with H. pylori will have a positive urea breath test. However, we have stopped doing this at UAB because so many people are concerned about taking radioactive carbon, so people in general declined the urea breath test. Stool antigen test is also very sensitive. The disadvantage of this stool antigen test is that patients have to return to deliver a stool sample. And in fact, in my experience and my colleagues' experience, most patients prefer a serologic test to bringing back a stool sample. The serologic test, or the IgG anti-H. pylori antibody test, is highly sensitive, it's inexpensive, it's non-invasive, and you don't have to stop PPI or antibiotics. And if someone is positive with a serologic test and has not been treated with antibiotics, then that person, by definition, is infected. Another important test is the CLO test. So this is a test for urease. Now, the H. pyloriase cleaves urea, alkalinizing a color-sensitive indicator. It's highly sensitive and specific, but obviously it requires endoscopy, and you certainly don't want to order endoscopy just to do a CLO test when you can do a non-invasive serologic test or a stool antigen test. And also H. pylori tissue histology is, when you see H. pylori, it's virtually 100% sensitive. I mean, the problem, of course, is that it's probably the least sensitive test due to sampling error. You could simply, the person doing the biopsy could simply miss the area in which H. pylori is present. And it also, like the CLO test, requires endoscopy. So overall, though, tests are 85 to 95% sensitive and 90 to 95% specific. Endoscopy is not performed to make a diagnosis, as I mentioned. Stool antigen is the most sensitive available test. Serologic testing is convenient, accurate, and always easy to perform in follow-up. So what drives at least my enthusiasm for the serologic test? Let's see if I can show here. Before I move on to that, I want to mention one other thing in follow-up. So who do we test in follow-up? And the indication nowadays is that really virtually anyone who's been treated for H. pylori infection should at some point be assessed for eradication. And assessment, of course, is individualized in that you want to determine what the patient's clinical features are, what's the age, the origin of the patient should be considered. Someone from the developing world, you want to make sure you cleared that infection because that person almost undoubtedly acquired their infection when they were several months of age. So they, when you see them, have had infection for years, if not decades. And those are the people have a high propensity for moving on through the cascade to gastric cancer. So those people should definitely be assessed for eradication. I have a patient who's 75, 80 years old and hasn't cleared his infection, although maybe he's no longer symptomatic. Do you want to test that patient again? It may not be necessary, since that patient is an adult, an adult Caucasian in the United States, is unlikely to move on through the cascade to develop gastric cancer. So age is certainly an important component of individualizing assessment of eradication. The assessment tests, the urea breath test, again, unfortunately, we don't do that here. Fecal antigen test, patients don't like to do that. Serology. Endoscopic biopsy for the Clo test or histology is problematic in that you have to do endoscopy. So when do we assess? Usually 4 weeks after the conclusion of antibiotic therapy and 2 weeks after PPI therapy. What I started to mention earlier is the convenience of follow-up testing by serology. And I really am a proponent of this for the following reasons. This is a study of 86 individuals who were followed at 3-month intervals with a urea breath test to confirm clearance. And what they showed that there was, and they compared people among the 86 individuals who received no treatment, who were treatment failures, and people who eradicated H. pylori. And they showed a decline in H. pylori IgA and IgG antibody titer at 6 months of 50%. What I generally do is request patients to come back in 6 months, and one should see a 50% decline in their antibody titer, and by 9 months or certainly a year, a marked, if not complete, resolution of their IgG antibody titer. So if someone comes back, they're asymptomatic, and their titer is somewhere around a decline in 50% at 6 months, I do not do endoscopy, and I do not actually have them come back after that. So I usually bring people back about 6 months after their therapy. So let's move on then and talk about gastric mapping. So when patients do undergo endoscopy, say for gastric ulcer disease or symptoms of gastric discomfort, and we biopsy them, we look for changes consistent with the chorea cascade. And an important feature of the cascade is metaplasia. And there are now a number of studies which show that when one progresses through the cascade to metaplasia, this is really an alarm feature in histology. And in the most recent study published in February in Gastroenterology, what these investigators showed, it really accentuated what was shown 12 years ago in the Netherlands, that about 1%, so about 1 out of 100 people with H. pylori infection who develop metaplasia will go on to develop gastric cancer within 5 years. Another important thing to remember is that in the biopsy, beginning about atrophic gastritis, but certainly in metaplasia and most definitely in gastric cancer, the chronic inflammation destroys the peptic, the ability of acid secretion in the mucosa. So with chronic inflammation and the loss of the parietal cell, the body of parietal cells that secrete acid, one often does not see H. pylori because H. pylori has lost its ecological niche. So in the absence of H. pylori and the presence of metaplasia and dysplasia, you still need to be very concerned that that H. pylori was present and that it is inducing further progression through the cascade. What is metaplasia? Well, metaplasia is the replacement of non-cardi epithelium with lower gut epithelium. There are 2 types of metaplasia. There's the complete intestinal type of metaplasia and the incomplete, more severe type of metaplasia. And these cells look like a colonic type epithelium with cytoplasmic mucins and the loss of the brush border. And this more advanced type of metaplasia is what is associated with progression to gastric cancer. So how do we go about mapping? Well, it's important to recognize that the prevalence of metaplasia is higher, significantly higher in Blacks and Hispanics, despite the same risk factors for other risk factors for gastric cancer. A single region may progress, or multiple regions of metaplasia may progress to dysplasia and gastric cancer. The endoscopist will take biopsies, 2 biopsies from the distal antrum, 1 biopsy also from the incisura, and then 2 biopsies from the corpus, recognizing that this sort of pangastritis or corpus gastritis is where we're most concerned about gastric cancer. But when it progresses to pangastritis, the location of the cancer is most predominantly in the incisura, this area right here. The studies looking at who should be followed once metaplasia is detected are not clear, but surveillance in general would be recommended if one is going to do it every 2 to 3 years. If the individual, the subject with the metaplasia, is from an endemic region. H. pylori itself does not reverse metaplasia, but it may slow progression to gastric cancer. So let's now look at who to treat, the antibiotics, antibiotic resistance, and convenience issues. So basically, all infected children, even children who were born and raised in North America or in Europe, should be treated regardless of symptoms, because they're going to carry their infection unless they're treated indefinitely, and with decades of chronic inflammation may progress to cancer. Infected individuals with symptoms or gastric pathology, infected individuals from developing countries such as Eastern Europe, Russia, China, Central and South America, subjects with multiple lymphoma. So this is the only lymphoma that can be cleared, can be resolved with antibiotic therapy, and then infected members of patients with gastric cancer. And a number of studies, again, several studies from Houston have shown that eradication results in clearing infection, ulcer healing, prevention of ulcer recurrence, restoration of the gastric microbiome, at least in children, which we published recently, and reduced risk for gastric cancer among all groups. So what is the usual regimen? Well, it depends. It depends on the local prevalence of antibiotic resistance. And in a very important study published in 2015 of 65 strains obtained from individuals with H. pylori infection, resistance to levofloxacin was 31%, metronidazole 20%, clarithromycin 16%, and importantly, tetracycline less than 1%, amoxicillin and rifabutin 0%. So these are now have become really sort of the staple antibiotics for therapy for H. pylori infection. This study also was performed in Houston. This has not been studied in the Birmingham area, but Houston is pretty close. And the population that was studied is not too different from what we see in Birmingham, Alabama. I have reviewed a number of studies, and I think that the bismuth quadruple therapy, including clarithromycin or the clarithromycin triple therapy, or is recommended. The clarithromycin triple therapy is no longer recommended because of the high incidence of resistance to clarithromycin currently in H. pylori strains. So what are the bismuth quadruple therapy regimens? So a very nice study of 424 patients showed greater than 90% eradication with the following regimen, and this is what I use: bismuth subsalicylate, 2 tablets 4 times a day, a PPI such as Prilosec, 40 milligrams twice a day, amoxicillin, 500 milligrams 4 times a day, and tetracycline, 500 milligrams 4 times a day. So I think this is pretty reasonable. 3 of the drugs are taken 4 times a day, and the PPI twice a day. There has been a decline in the availability of tetracycline. So doxycycline, 100 milligrams 4 times a day, is an alternative agent for a tetracycline. When I checked a couple years ago for how much this regimen would cost, with insurance, the UAB pharmacy said that the bismuth would be about $6 for a 2-week supply, the PPI about $12, amoxicillin $8, doxycycline $8, so $34 for a 2-week course of therapy for H. pylori infection. The major reasons for treatment failure are, first, antibiotic resistance, and 2, poor compliance. And by poor compliance, it means often not taking the prescribed number of antibiotics per day, or less than 14 days. Rescue therapy after a failed initial treatment is usually 90% effective if the individual is compliant with their therapy. And the rescue therapy, there are 4 regimens that are recommended by the American College of Gastroenterology. And these include bismuth, PPI, amoxicillin, tetracycline. So basically, repeat the original therapy. And secondly, increasing the amoxicillin to 1.5 grams TID. Levofloxacin can be also used in place of the amoxicillin. And then furazolidone, a liquid form, is quite helpful in children. When rescue therapy fails after 3 treatments, rifabutin can be substituted for the tetracycline. Antibiotic susceptibility testing is definitely available, and you can request that when you send a patient to one of us in the division. This requires endoscopy, and the biopsy is sent to Quest Diagnostics for culture and antibiotic testing. So what are some relevant clinical pearls? And then I'll make one final comment, and we can take any questions if we have time. So first of all, improved hygiene and increased use of antibiotics are associated with reduced prevalence of H. pylori infection in the United States and in Europe compared to the developing world. H. pylori prevalence is declining in the incidence of, there's a declining H. pylori prevalence that correlates with decreasing incidence of distal esophageal cancer. And this is really due to the following reasons. H. pylori-induced hypochlorhydria protects against Barrett's esophagus and the consequences of Barrett's esophagus. And there is some suggestion, although it's not been studied, that H. pylori eradication may worsen reflux symptoms. And that would be because with the clearance of H. pylori and the reinstitution of parietal cell function, of acid secretion, the reflux symptoms can be exacerbated. H. pylori infection associated with iron deficiency anemia promotes gastric cancer. H. pylori eradication in subjects with a first-degree relative with a history of gastric cancer significantly reduces the subject's risk for gastric cancer. It's published in February in the New England Journal of Medicine. Beautiful data that H. pylori eradication reduces the risk for gastric cancer, and CAG-A is the major risk factor for H. pylori associated gastric cancer. So I'd like to make one final comment. When I was a medical student, I was taught by our parasitology teacher that Napoleon Bonaparte, in this beautiful painting by Jacques-Louis David, who's in the who painted in Paris in the early part of the 19th century, that he was scratching as a consequence of lice. But I was taught before we really discovered H. pylori infection, or just about that time we learned about H. pylori infection. So I'd like to make the following points. Now, Napoleon Bonaparte began suffering from, quote, violent stomach pains after the Polish campaign of 1806, as recorded by Will and Ariel Durant in the Age of Napoleon. He had his first upper gastrointestinal bleed on May 3rd in 1821 and died 2 days later on St. Helena. The autopsy by a famous French pathologist was attended by 7 British surgeons on May 6, 1821. So many British surgeons because I guess people were concerned that Napoleon may not be dead and could potentially escape once again from his imprisonment. He had at autopsy a perforated gastric ulcer, peritonitis, and a distal gastric cancer. Importantly, Napoleon's brother, 2 sisters, father, and possibly his father's sister died of gastric cancer, all exemplifying the familial clustering of H. pylori associated gastric adenocarcinoma, although obviously we don't know that he had H. pylori, but clearly the epidemiology and the demographics of Napoleon and his family really do implicate H. pylori, and Napoleon palpating his painful duodenal ulcer. So with that, I'll thank you and take any questions.
Thank you very much for that very interesting talk. A couple of points that I picked up. I was not familiar with H. pylori primarily being an infection acquired in childhood, and that you really carry this with you, and it's not till years and years later then it manifests. One of the questions that came up on the chat was about reinfection rates, and so you've had this since childhood. Did you say in developed countries it's actually fairly rare once you've eradicated H. pylori to get reinfection?
Yes, once it's been eradicated, the acquisition rate is 1% per year, in sharp contrast to the developing country, where it's up to or more than 12% per year. So that you need to keep that in mind if you have problems trying to eradicate H. pylori in someone.
Fantastic. We're at the 1 o'clock hour, so anyone that has to drop off, please feel free to do so. We've got 2 more questions, and then any other questions anyone else wants to put in the chat. I thought it was very interesting to actually use the serology as a measure of eradication. I was not familiar with using the titer and following a drop in titer. And so did you say looking at 6 months out, it's really a 50% drop in titer, that if someone has that on the serology, you can rest assured that they've eradicated their H. pylori infection?
That's correct, yeah.
Okay, fantastic. So the last question from Dr. Estrada was with we're now doing the bismuth quadruple therapy as kind of the standard first line. What are the usual compliance rates, either in research studies or in clinical practice, that you have seen? It's a 4-time-a-day regimen. How difficult is it to get people to adhere to that? Do you have any pointers on that?
Well, that's that's a very good point. Um, I just try to really emphasize patients that it's a complicated therapy and that they must adhere to that regimen. Um, the three of the agents, as I mentioned, can be taken together, but they should be taken 4 times a day. The PPI is only twice a day, but if they take them together, it's a little easier for them to remember that it's 12 o'clock, I need to take my second dose of these 3 agents. It is a problem. And in some studies have shown that actually its compliance, at least, well, certainly the ineffectiveness of therapy in people who are taking amoxicillin and tetracycline, and when they fail therapy, it's compliance and not antibiotic resistance. That's the main cause of persistent infection.
So that makes sense why the susceptibility rates were so high for those antibiotics, but you may not always clear it if the medicine doesn't get into the patient. That makes sense. Well, I think that is the last question that we had on the chat. So thank you very much, Dr. Smith, for your time. And wait, we've got one more.
Okay.
We say, do we think we'll be asked to choose how to test serology versus urea breath test versus stool for someone who meets screening guidelines, which seem a little difficult outside of suspicious area, malt, adenocarcinoma, or metaplasia? So on the internal medicine boards, I think the question is, how do we know whether to test serology, urea breath test, or stool for someone? This by screening guidelines, they may mean like a test and treat or something like that approach. Do you think that a question will come up of how to choose the most appropriate H. pylori test?
Well, I think I tried to be practical about emphasizing the importance of considering a serologic test. But for the boards, probably the best test is urea breath test because that's the most sensitive. If you have a positive breath test, you are infected. And either the urea breath test or the stool antigen are really recommended by the societies as as clearly the best way to follow up someone for clearance. But as I said, we don't do the breath test here, and people would much rather get a blood test than submit a stool specimen.
That's fair enough. And the other thing I think that may come up on those board questions is a patient on a PPI that can't be stopped or something like that. Which test would you choose?
Serology.
And in that question, the answer would be serology, since for both the stool antigen and the urea breath test, you have to be off of the PPI. So that may be another way that they kind of force you to choose one way over another.
Uh-huh.
All right. Well, that concludes this lecture. So thank you very much, everyone. Thank you very much, Dr. Smith, and y'all have a great day. Bye now.
All right. Bye-bye.